Okay, as I shared with you the book of ATLS 10th edition, we will start with the first chapter, which is initial assessment and management. So I will try to summarize the important points to you so you have to remember them. Look, before I will go inside this chapter, look, if you have a trauma patient in the street, what you will do? If you have a traumatized patient in the street, what is the job of doctors to act in such scenario? Look, the job for doctors and medical team who supply the assistant for that patient is to prepare for the situation and to triage for this situation and to give ABCD, the primary survey with adjunct and the secondary survey with adjunct, let me say. So preparation, triage, primary survey, secondary survey, and to give definitive care. This is our aim of ATLS, to make a good preparation and good triage and good primary survey and good secondary survey and good definitive care. Okay, so regarding the preparation, to prepare for any trauma patient, you need the following things. You need to know what we can do in a pre-hospital phase, what we can do in hospital, and what we can do in follow-up that patient. So in pre-hospital phase, this is very important. What we do in, let me say, in ambulance or in the street. First thing, if you have an accident occur in front of you in the street, your action will be like this. Just a second. You have to notify the emergency team. You have to notify the first thing. If you were standing in the street and you notify a trauma, please notify the emergency team like 911 or in Iraq 122. This is in Iraq only. Okay, so notify the emergency team. And once the emergency team reach the patient, they will try to maintain airway and to stop bleeding and to do immobilization of patient and then transport to trauma center or emergency department. Again, regarding preparation in pre-hospital phase, the first thing, the most important thing is to notify the emergency team, by calling them 911 or 122 in Iraq. And then the team will have airway management technique, and we will discuss airway in details in next chapter. And they will control bleeding, and they have to immobilize the patient and transport it to the nearest emergency department or trauma center. Okay, look, the pre-hospital team ideally set up to notify the receiving hospital. It's set up to notify the receiving hospital before the transport of the patient. Again, they have to control airway and control external bleeding and shock, immobilize the patient, and immediate transport, as we discussed. This triage is not so important for you. The triage pre-hospital for doctors is not important. Now, what we will do in hospital, and this is very important. This is doctor's job. This is the job for you. Okay. Critically, you have to prepare the hospital, prepare the trauma center. By what? First thing you have to know that resuscitation area is available, like the red zone, what we call it the red zone, or trauma room. Second thing, you have to be sure of airway equipment. Third, you have to have warmed IV line, this IV fluid. This is very important in a trauma patient. You have to be sure that you have a warmed intravenous crystalloid solution, and you have to follow up the protocol of your hospital in management for trauma patient. So in hospital, again, what is important in hospital to be prepared for a trauma patient? Number one, you have to be sure of having a resuscitation area or resuscitation room or a trauma room. Number two, you have to be sure of airway available, airway equipment available in this trauma room, and you have to be sure that you have a warmed IV fluid and the protocol to be followed by your hospital. Now, regarding triage of patients. Triage of patients, beside the triage of color, the red, the green, the yellow, the triage here, they depend on sorting patients based on resources requirements required for treatment and resources available in hospital. For example, they divide the triage into multiple casualty and mass casualty. Look, for multiple casualty, they mean that you have, for example, your ER have 20 beds, and you receive a multiple patient of a multi-trauma patient of 10 patients. So you have a 20 beds, and the patient is less than the ER bed, so you can handle those patients in this hospital, in this emergency department. While mass casualty, if you have a 20 bed, but you have 30 patients. So here, this is called a mass casualty. The patient is the patient's number beyond your capability to deal with them all. So if you have a 20 bed, of course, you cannot deal with 30 traumatized patients in that hospital. So this is the triage according to resources. Okay. Now we will speak about primary survey, which is very, very, very important. Okay, any question until now? I will take 2 minutes to receive your questions. Okay, now we will speak about the primary survey in simultaneous resuscitation. Look, primary survey, simply primary survey is A, B, C, D, E, which all of you know. This is very important to be understood. So A is for airway, B for breathing, C for circulation and hemorrhage control, D, disability management, or let me say assessment of a neurological status, and E for exposure. Look, if you are well trained and if you know what to do in ABCD, you will do it in 10 seconds. It takes 10 seconds for assessing the airway and the breathing and circulation disability and to do exposure for that patient. Look, now we will start about airway. What's important in airway, and this is just a short note. We will explain airway in details in next class. So airway patency, we have to check airway patency. If the patient can talk, let me say, if any patient can talk, this mostly mean patent airway. If the patient can talk, this is a patent airway. You have to check for any fracture, you have to do suctioning, and you have to restrict cervical movement. Look, let me say action if you have airway problem. If you have suspicion of airway problem, what you will do? We will discuss this later on by just a second. Later on, we will speak about a basic airway and advanced airway. So what I mean by basic airway and advanced airway, if you have, again, if you have a patient who can talk, this means patent airway. If not talk, traumatized patient who cannot talk, this means that there is something problem in airway. What you will do a basic technique and you can call for help for advanced technique. What are the basic technique? We will discuss it in next class, but I will give you just a hint. Basic techniques like head tilt, chin lift, jaw thrust, and putting an oropharyngeal airway. While advanced airway technique like endotracheal intubation, like PTLV, percutaneous translaryngeal ventilation, like surgical cricothyrotomy and tracheostomy. So those called advanced, starting from ETT, endotracheal intubation, to the last surgical tracheostomy. Basic airway is your job to do it. It's simple to make a head tilt, chin lift, and also to put an oropharyngeal or nasopharyngeal airway. So here, I just make an action. What you will do, if you have a patient with airway problem, you have to do first thing is suction the mouth of that patient, and then try to do jaw thrust or chin lift, and then try to put an oropharyngeal airway or nasopharyngeal airway. If the patient still airway is not secured, you can call for help to do advanced airway. So all these are basic, while this is for advanced. Again, what's your action? If you suspect an airway problem, your action will be first, do suction for the mouth. Number two, do jaw thrust and chin lift. But again, keep the neck in natural position. Do not do any manipulation for the neck. This is better in traumatized patient unless you are sure that there is no cervical spine injury. And do put oropharyngeal airway or nasopharyngeal airway. This will be shown in next class. And advanced airway like endotracheal intubation, cricothyrotomy, and PTLV and tracheostomy. And this also will be discussed in details in the next class. Again, head injury, usually if you have head injury in like with the Glasgow Coma scale less than 8 or less, you can definitely, this patient need putting endotracheal intubation. So this is how we can, this is very important, this is how we can keeping the neck for the patient stable. It's very important. Cervical spine motion restriction. Once you as a doctor, once you transfer a patient from a traumatized patient from a bed to bed, please be the one who is here. You have to maintain the cervical spine motion. This is you cannot depend on the chairman, those who walk, who take the patient from bed to bed, the normal people, the relative of patient. Please do it yourself. Once you have a traumatized patient to be transferred from bed to bed, please be the one who is maintaining the cervical spine from movement. Now, second thing, breathing and ventilation. Please, in a breathing and ventilation, the idea is to detect any chest problem and to detect any oxygenation problem and to deliver oxygen and to treat those conditions. Again, in breathing and ventilation, our aim is to give oxygen and to treat pneumo or hemothorax. By what? By needle thoracotomy, and then we can put chest tube. So oxygenation of traumatized patient is very important, and also detecting of pneumohemothorax and putting a needle decompression, and this will be discussed also in details how to put a chest tube and how to put needle decompression when we will take the chest trauma. So in a breathing, you have to give oxygen and to detect pneumohemothorax. How to detect pneumohemothorax in a rapid way? Simply, if you have a trauma patient and you put your stethoscope in the chest of the patient, the right upper, the right lower, or the right middle, and the left 3 area, and you hear a diminished air entry or no air entry, this means there's a problem in the chest. It could be pneumo or hemothorax. You have to put the needle. Again, how to detect pneumohemothorax in a trauma patient rapidly, just by stethoscope. Put your stethoscope in a 3 area of each side of the chest, like upper, middle, lower zone of the right side, upper, middle, lower zone of the left side. Listen carefully, compare both sides. If you hear diminished air entry or no air entry in any side, please, there is a problem in the side and you have to put a needle. Where to put a needle? We will discuss this later on. But it is in the safe triangle, the same triangle of the chest tube. Previously, it was second intercostal space, but this was changed in the new ATLS to be in the safe triangle of chest tube, except in children. I don't remember the age, except in children, but I think it's up to 8 to 10 years. And in children, it is still in the second intercostal space, midclavicular line. Okay? So, again, in breathing, give oxygen, treat pneumo or hemothorax by needle, and then the tube. Now, regarding circulation, circulation and hemorrhage control. This is very, very, very important point. Regarding circulation, what we will do, we have to do, I summarize it here. We have to do putting 2 IV lines and taking a blood sample for investigation, give IV fluid, and again, the IV fluid should be warm or hot IV fluid. Okay, stop bleeding, prepare blood to be given, and give, nowadays they give tranexamic acid. Okay, tranexamic acids, it is cyclocapron, if you know it in your emergency department, cyclocapron ampoule or vial. Okay, again, what you will do in circulation and hemorrhage control, you have to put 2 IV line to give warm IV fluid, stop bleeding, prepare blood, prepare and give blood, and give tranexamic acid. What about the bleeding? How to stop bleeding? Simply and very, very important is put your hand, use your hand. If you receive, I remember a patient with femoral injury, femoral artery injury. We received this patient. He was a boy of 15 years old, presented with a blast injury and a trauma to the main femoral artery. So we receive a patient in fourth degree shock, fourth degree shock. Unfortunately, the bleeding was not controlled outside the hospital, but fortunately, inside the hospital, by just putting my hand, just putting my finger over the femoral artery, we do good resuscitation over 10 minutes, and the patient consciousness regain to be conscious, and the bleeding control by just direct pressure until the operation room become clear, so we can put this patient for operation. And also we did for him, as I remember, we did for him a femoral artery repair by saphenous vein. I don't remember from which vein we took, but we did a femoral artery repair for that patient. There was a loss of 4 cm from femoral artery. Okay, so direct pressure, I remember this patient become alive by just direct pressure, which is done in the emergency department in the trauma room. After direct pressure, we can do ligation. Also, I remember many cases we did ligation of radial artery or ulnar artery, and the patient become good. Also, we can do cauterization for tiny arteries in the emergency department if we have cautery. And lastly, as I said, repair of the artery. So this is how to stop the bleeding in general in the emergency room, in the trauma room or emergency operative room. Prepare and give blood. Look, what is the blood to be given? It is usually O negative blood. Usually we use O negative blood. The idea is to give packed RBC. The idea is to give packed RBC and to give whole blood if you don't have packed RBC. Also, we will give a cyclocapron tranexamic acid. Now, some clinical observation to be seen for a patient with shock, we will discuss also in chapter of shock for more details, like level of consciousness of that patient, skin perfusion, and pulse. Let me say rapid, thready pulse is typically sign of hypovolemia. Regarding bleeding, also we speak about how to control the bleeding. Okay, now how much fluid we can give? This is very important. How much fluid we can give for that patient? We can give for a traumatized patient 1 liter as a bolus of IV fluid. We can give 1 liter as a bolus of IV fluid. Look, they found European and American military studies, they found that improved survival when the tranexamic acid is administered within 3 hours of injury. So there is a guideline, and we will see it later on, not in this class. In the last class, we will speak about tranexamic in injury patient. So I preferred to give tranexamic acid within 3 hours, as those studies said. Now, regarding the disability, which is a neurological evaluation, this is very important to know. I don't want you to take a full history for a patient with trauma, a full history of neurology, and a full examination of neurology. In the primary survey, I want to know just if our patient is one of these IVPU, AFPO. Is the patient is alert? Is the patient responds to voice? Is the patient just respond to pain, or the patient is unresponsive totally? So this is only what I know. This is what I need from you. And please note the following just for you. If you have a patient with the trauma and decreased level of consciousness, this could be head trauma and also could be from hypoglycemia and could be from alcohol, could be from narcotic and other drugs. So this is very important. Not every decreased level of consciousness in the traumatized patient is from head trauma. There are differential diagnoses for the decreased level of consciousness. Again, if you receive a patient with decreased level of consciousness after trauma, think about first head trauma. And don't forget to think about drugs. Don't forget to think about hypoglycemia, which is very common in a traumatized patient. And don't forget to think about alcohol and narcotics. Regarding exposure, this is very important to be you have to expose your patient totally so you don't miss any injury in that patient. And also during exposure, remember that hypothermia is very common in a traumatized patient. So please control the hypothermia in those traumatized patients. How to control? Take aggressive measures to prevent the loss of body heat and restore body temperature. How? By giving IV fluid, which are warm IV fluid. This is very important. As you see, I always say give a warm IV fluid because this is very missed in the emergency department. So regarding the pitfall, how in the exposure, the hypothermia can be present on admission and the hypothermia can be developed after admission. So hypothermia in a trauma patient is very common. It can be occur before admission, it can be occur during admission, and you have to deal with it. How to deal with it? By warm environment, warm the room of trauma patient, and warming the room of trauma patient by warm blanket and warm IV fluid. Okay. Now we will discuss about just a few minutes for the adjunct, then I will take questions, then we will take a break. Okay, now what are the things or the investigation or the something you can do beside the primary survey? Beside the primary survey, it's very important to send the patient for ABG, arterial blood gas analysis, to check the SpO2 oximeter for that patient, to do ECG if you have suspicion of cardiac injury or chest injury, and you can send you can put Foley catheter and NG tube for some patient. And regarding investigation, X-ray and EFAST considered in the primary survey. So again, ABG, arterial blood gas analysis, SpO2 you have to see, ECG you may send if you need, if you have chest trauma and suspicion of cardiac injury, and Foley and NG tube also can be inserted. EFAST is one of the adjuncts in the primary survey, and X-ray. So cardiac injury, blunt cardiac injury, can cause a pulseless electrical activity, tamponade, which is indicate cardiac tamponade, tension pneumothorax, or profound hypovolemia. And extreme again. I will repeat it many times. Hypothermia may produce this arrhythmia. So hypothermia, please control hypothermia in your trauma patient. This is very dangerous and it may lead to many complications. Pulse oximetry, what else? Okay. So consider need for a patient transfer. We will stop here to receive any question and then we will take a break. So any question, please?